Thank you for the opportunity to speak this afternoon. I have no financial relations or conflicts of interest to disclose. Today I'm going to be talking about laparoscopy and trauma surgery, particularly the risks and benefits, as well as the appropriate patient. I will follow this up with a case review applying these principles. A familiarity with the history of trauma surgery is useful when discussing the current state of surgical management for abdominal trauma. The early management of abdominal trauma was exclusively non-operative management. This was managed with compresses, opium, and bloodletting. Understandably, this led to a very high mortality rate. There we go. By the early 1900s, there was a transition towards surgical management of abdominal injuries, and by World War I, it was standard management for abdominal trauma. After the war, though, with a transition back to civilian practice and lower velocity injuries, there's a high rate of negative or non-therapeutic laparotomy in trauma. Associated with this was a high mortality and morbidity rate. Because of this high morbidity rate, by the 1960s, there was a push for selective non-operative management of trauma patients. This was based almost exclusively on abdominal exam and physical exam to determine which patients should undergo exploration and which ones were appropriate for non-operative management. While this did improve the negative and non-therapeutic laparotomy rates, they were still relatively high. Additionally, there was always concern for missed injuries that would then become worse and worsen outcome. This gap between all or nothing approach to trauma patients resulted in multiple adjuncts being developed in order to try to answer the question of who was at risk for a missed injury versus who was at risk for a negative laparotomy. These include diagnostic peritoneal lavage, ultrasound, local wound explorations, and CT scans. Although laparoscopy was introduced much earlier, in the early 2000s was when the utilization of laparoscopy, particularly in elective surgery, began to increase rapidly. Laparoscopy for trauma was much slower to take off, but as the advantages of laparoscopy in elective practice became apparent, there was this transition for trauma as well. Initially, it was used just as another screening tool, so similar to the other adjuncts, and if there was positive violation of the peritoneum or an obvious injury, then the next step would be immediate conversion to a laparotomy. This was particularly useful for patients with ambiguous exams or CT imaging. However, it was much slower to be taken up in trauma. There was a resistance to change for a few reasons. There was initially a missed injury rate of upwards of 70%. The therapeutic options were very limited. Again, it was being used mostly as a screening tool. And the initial studies failed to show significantly decreased length of stay or costs. However, as the experience grew, the techniques improved and more systematic approaches were created, and now the risk of a missed injury is less than 1% in most studies. Additionally, with the transference of skills from elective laparoscopy, the therapeutic options are much improved, and they have low morbidity and mortality associated with these techniques. Additionally, newer studies have confirmed a slightly decreased length of stay, although the cost differential has not yet played out that way. The formal indications for a trauma laparoscopy are suspected but unproven intra-abdominal injury after blunt or penetrating trauma in a hemodynamically stable patient. These include patients with suspected injury based on exam despite an otherwise negative workup, such as free fluid in the absence of solid organ injury, or for patients who have penetrating injury of unclear trajectory. However, as laparoscopy becomes more useful for trauma and more used, at this point you can use laparoscopy for proven intra-abdominal injury as well, as long as the patient is hemodynamically stable, including after initial resuscitation. It is key, the patient selection is key to successful laparoscopy for trauma, and this is going to vary widely from institution to institution, as well as from surgeon to surgeon, based on their experience with laparoscopy, equipment, and operating room resources available, as well as supporting services, for example, interventional radiology for endovascular procedures. The main contraindications to a patient undergoing trauma laparoscopy is a hemodynamically unstable patient, including transient responders, inability to tolerate pneumoperitoneum for whatever reason, including comorbidities or increased intracranial pressure or additional injuries sustained. The main techniques for trauma laparoscopy are very similar to elective laparoscopy. The most common is an open or Hassan access technique, followed by direct visualization or OptiView. It is generally recommended to avoid a varus needle, and this is mostly due to the risk for iatrogenic injury and a non-fasting trauma patient due to potential bowel dilation. That being said, it hasn't been shown in trauma literature to actually be an independent risk factor for iatrogenic injury, partly because it isn't used very much, but I think that overall the key is to get into the abdomen in the way that you're most comfortable. Additional working ports would then be placed. These are typically 2 5mm ports as working ports, and placement is going to be determined based on where the suspected injury is or trajectory of a penetrating injury. So they can be upper abdomen, lower abdomen, or if concerned for a small bowel injury and you're planning on running the entire small bowel, the left side of the abdomen. There are multiple approaches to trauma laparoscopy. The main thing is to be standardized and systematic in order to help minimize missed injuries. The approaches overall mimic open laparotomy in that you're doing a full evaluation of the abdomen, including looking at the diaphragm, the solid organs, the hollow viscus, and the retroperitoneum, including the lesser sac. Again, initially, trauma laparoscopy was used as a screening tool, and any injury would necessitate immediate conversion to a laparotomy. However, now it's mainly used in 2 ways. The first is a diagnostic and localization instrument. So a laparoscopy would be performed, injuries would be identified, and then a much smaller laparotomy would be performed to address those injuries, such as a small bowel resection. This limits the size of the incision compared to the traditional laparotomy for trauma, which is from the xiphoid to the pubis. This would be much smaller and limited, which also decreases morbidity. The other way it's used is as purely therapeutic, so doing all the interventions laparoscopically. It follows the same principles as if these injuries are encountered during laparotomy. So simple repair of anti-mesenteric small bowel injuries could be a suture repair versus doing a full resection. Diaphragm injuries can also be repaired laparoscopically. Management of liver bleeding can be taken care of laparoscopically, whether with compression, hemostatic agents, or packing. While splenectomy is not recommended in the acute trauma setting, a delayed laparoscopic splenectomy can be performed, particularly after failure of angioembolization. There are some findings during laparoscopy that may limit ability to manage it. Retroperitoneal injury that requires further intervention or examination should probably be converted to an open procedure. Major vascular injury would be better managed open. Duodenal injury due to limitations or difficulty with mobilization, although this is very surgeon dependent. A heavily scarred abdomen would be very difficult to do laparoscopically. And diaphragmatic injuries, while again can be treated laparoscopically, you do have to be worried about the risk of tension pneumothorax and be ready to intervene if that develops. So at this point, I'd like to go over a few cases that I had on my last call. So the first is a 5-year-old female who presented 24 hours after an ATV accident. She had a roll down and embankment in the front. She struck the handlebars, and then her dad landed on top of her. Initially, she had no complaints. However, over the 24 hours, she was complaining of worsening of abdominal pain and developed nausea and emesis. At presentation, she was hemodynamically normal, and she did have bruising and abrasions to the lower abdomen and near her belly button. She was also tender to palpation in the right lower quadrant. Her FAST was negative. Given this history, she did get a CT scan, and she was found to have trace fluid in the right abdomen, no free air, but the fluid was underlying the injury and the location of her pain, so the decision was made to proceed with diagnostic laparoscopy. We found a small contained kind of mesenteric hematoma extending into the right pelvic retroperitoneum, otherwise negative, and all of the bowel was viable on further inspection. After this, the patient was admitted overnight, her diet advanced, her pain controlled, and she was able to be discharged the next day. I brought up this case because I want to point out that trauma laparoscopy is safe and effective even in pediatric patients. It does tend to have higher utilization in level 1 trauma centers compared to level 2 or less, likely due to experience as well as instrumentation that's specific for the pediatric population. Additionally, trauma laparoscopy is safe and effective in patients with blunt trauma. This is particularly useful in patients who have a concerning exam but negative imaging, patients that you're unable to obtain an exam on, such as head trauma or intoxication, as well as if there's imaging findings of unclear significance, such as this patient with free fluid without solid organ injury. A second case is a 30-year-old male who was stabbed by an unknown assailant in the epigastric region. He presented hemodynamically stable, non-peritonitic, and had a 1 centimeter laceration in the upper abdomen. His FAST was negative. In this patient, there's multiple different options. We could do the selective non-operative management, given his benign exam. There is a risk for a missed injury in that setting. Diagnostic laparoscopy or exploratory laparotomy would also be possibilities as primary treatments, but they have higher morbidity associated with them. If you are going to do selective non-operative management or for operative planning, a CT scan would be very helpful. It can help delineate the appropriate approach. If there's no violation of the anterior fascial sheath, then non-operative management would be appropriate. If there is violation, with or without underlying injury, can help determine if this patient would be more appropriate for a diagnostic laparoscopy or exploratory laparotomy. So we did do a CT scan in this patient and found that he did have free intraperitoneal air. He underwent diagnostic laparoscopy, was found to have a small violation of the peritoneum and a small non-expanding omental hematoma. The rest of his trauma laparoscopy was negative and no interventions were needed. Again, he was able to eat immediately after surgery and was discharged in less than 24 hours. The third case is a similar patient, 22-year-old male, stabbed by an unknown assailant to the epigastric region, also hemodynamically stable at presentation, non-peritonitic on exam, and he had a 1 centimeter stab wound with a small tongue of omentum that had eviscerated. He did have an equivocal FAST for right upper quadrant fluid. In this patient, he's not appropriate for selective non-operative management because he has clear evidence of violation of the peritoneum. However, he could either get a CT scan or go direct to the OR for diagnostic laparotomy and exploratory laparotomy. However, again, I think in this patient population, a CT scan is very helpful to determine trajectory, to give you an idea of what might be injured and other resources you might want. And in this patient, even though he was completely stable and had minimal pain, he had a very large retroperitoneal hematoma and evidence of through and through injury of the pancreas and the aorta. Because of this, we obviously did not do diagnostic laparoscopy. We did take him to the OR. Knowing his injury pattern, we were able to initiate the massive transfusion protocol well before he became unstable. He underwent bilateral groin access for intra-aortic balloon placement for occlusion if needed. He did get an XLAF found to have through and through at the level of the pylorus, which were oversewn, pancreatic injury, which was drained, and then he ended up needing a intraposition graft of the aorta due to those pseudoaneurysms at the level of the right renal. The reason he was stable is because his left renal vein had actually compressed the injury, and so he managed to survive to the hospital. Interestingly enough, he actually survived 8 hours because he was 3 hours away and snowed in before he could actually make it down to Anchorage. So that poor little left renal vein did a lot of work. So why are we talking about laparotomy during a laparoscopy talk? It's because even though patients may present with seemingly benign pathology or injuries, they can actually have a lot going on inside. So hemodynamically stable does not always mean that diagnostic laparoscopy is appropriate. We use CT scans a lot in blunt trauma. There seems to be some hesitance in doing it for penetrating trauma a lot of the time, particularly if the decision for operating has already been determined. However, that may be a kind of a remnant from historical management of penetrating trauma straight to OR. And there's also a lack of studies that really assess the use of CT in operative planning for penetrating trauma. However, in the radiology literature, there's a lot of evidence that it's both sensitive and specific for predicting the injuries that may be encountered. If you can predict the injuries encountered, you can then have the appropriate resources available, and it may change your management, including using a hybrid room versus a standard trauma room, if that's how your surgery unit is in your hospital. So in conclusion, trauma laparoscopy is safe and effective. Patient selection is key, and surgeon expertise and comfort varies, and it correlates with the successful laparoscopy for trauma versus converting to a laparotomy. And then CT is useful adjunct even after decision for OR has been made. Thank you.